Now I will talk on talus fractures. Coming to the epidemiology, talus fracture is the second most common tarsal fractures after calcaneal fractures. Less than 1% of all the fractures. In that, talar neck fractures are most common. They constitute almost 50%. Talar body fractures account for almost 13 to 23% of the talus fractures. Lateral process fractures account for 10.4% of talus fractures, and talar head fractures, least common talus fractures. Coming to the mechanism of the injury, talar neck fractures are usually high energy injury fractures caused by forced dorsiflexion with axial load. Talar body fracture often result from high energy trauma with the hind foot either in the supination or a pronation. Talar process fractures are caused by injuries from the forced dorsiflexion, axial loading, and inversion with the external rotation, often seen in snowboarders. Patients will usually present to the emergency after an accident or fall with the pain, swelling, deformity of the ankle. We have to reduce the subluxation and dislocation if it is there urgently to avoid skin complications. Initial investigation is an X-ray. After that, if required, do a CT scan or an MRI scan. After stabilizing the patient, we have to see the accident CT scan. If it is non-displaced lateral process fracture, non-displaced posterior process fracture, non-displaced talar head fracture, non-displaced talar body fracture. It means non-displaced here means less than 2 mm of displacement. And Hawkins type 1 talar neck fractures are treated by conservative method, that is by below knee cast and limb elevations and painkiller tablets. If it is displaced, then operative fixation is required. Fractures of the talar neck and our body have not only been difficult to treat but have been associated with high rates of osteonecrosis ranging from 12 to 50%. Coming to the talar neck fractures. Isolated talar neck fractures are unusual and are frequently associated with a combination that extends into the body. Crush injuries of the talar body are associated with the talar neck fractures. There is a separate classification for the talar neck fractures. Hawkins 1 means non-displaced, 2 is associated with subtalar dislocation, 3 subtalar and tibiotalar dislocation, 4 subtalar, tibiotalar and talonavicular dislocation. Coming to the treatment of displaced talar body and neck fractures, displaced talar neck and or body fractures should be treated with the open reduction and internal fixation. Time to surgical fixation should be minimized. A delay does not appear to adversely affect the outcome, specifically with regard to the development of osteonecrosis. Post-traumatic arthritis, particularly affecting the subtalar joint, appears to be much more common than osteonecrosis. Osteonecrosis develops after 50% of the isolated displaced talar neck and or body fractures, and probably is a result of the degree of displacement and associated open injury. Patients with a displaced fracture talus should be considered that post-traumatic arthritis and chronic pain are expected outcomes even after anatomic reduction and with no evidence of osteonecrosis. Overall union rate is 88%. Coming to the complications, avascular necrosis happens in almost 30% of patients. Talonavicular arthritis, malunion, chronic pain from symptomatic non-union, subtalar arthritis in 50% of patients, tibiotalar arthritis 33% of patients, and stiffness. These are some of the common complications.